welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Now we have Christine Wu, who is a PGY1 resident at the University of Michigan Health. Today, she will be presenting a journal club on post-intubation sedation of pediatric patients in the ED, a systemic review and meta-analysis. Thank you.
So this was a systematic review and meta-analysis conducted by these following authors, which I'll touch upon a little bit later. So going into some of the background, as we all know, post-intubation sedation typically occurs after we have mechanically ventilated the patient, as they both still experience pain and agitation, which can occur for a variety of reasons. And so SCCM does recommend using like an assessment-driven, protocol-based, and stepwise approach for pain and sedation management after mechanical ventilation. Furthermore, post-intubation sedation is critical for patients undergoing mechanical ventilation to ensure comfort with the ventilator synchrony and reducing also psychological stress. It also prevents anxiety, agitation, and so on and so forth. However, the appropriate selection, initiation, and titration of post-intubation sedation in the ED has a significant impact on key downstream patient-centered outcomes, including delirium, coma, length of mechanical ventilation, and incidence of awareness under paralysis. So most of the existing work in the ED for post-intubation sedation has been performed in adult patients, and the guidelines on sedation and analgesia are typically for NICU or PICU settings, but there's no society recommendations or guidelines addressing pediatric post-intubation sedations in the ED. And nearly all intubations in adult and pediatric EDs are performed using rapid sequence intubation, which we all know is a sequential approach to prepare, sedate, and paralyze prior to intubation, which again, a sedative and also a neuromuscular blocking agent specifically are given nearly simultaneously. So going into some of the previous trials that have been done, children are about half as likely as adults to receive post-intubation sedation in the ED, as there are limited prior studies. Data from the National Emergency Airway Registry indicate that the use of longer-acting neuromuscular blocking agents is associated with lower odds of receiving post-intubation sedation compared to the short-acting ones. And then pediatric patients undergoing rapid sequence intubation often receive long-acting neuromuscular blocking agents just due to the concerns about harm associated with succinylcholine in patients with undiagnosed neuromuscular disorders, which may place also pediatric patients at increased risk of paralysis without adequate sedation. And then there are limited published data, as we've said previously, regarding current post-intubation sedation practices in the pediatric patient intubated in the ED. And so despite the fact that we extrapolate from the ICU and also adult ED literature, some of that also suggests that pediatric patients are likely at risk for significant clinical harms associated with inadequate post-intubation sedation. So going over our study overview of our meta-analysis and systematic review, they want to systemically describe and identify the current knowledge gap regarding pediatric ED post-intubation sedation to better characterize these practices and also support research and quality improvement. So this was done using the following databases of MBase, Ovid, Medline, Scopus, Central, the Cochrane database of systematic reviews, and also the clinicaltrials.gov. And they did a systematic review and meta-analysis again of this global medical literature regarding the use of post-intubation sedation in this pediatric ED patient population. So they included studies that described post-intubation sedation in patients that were less than 18 years old, intubated in the ED via RSI. And they included randomized and non-randomized studies and included also subpopulation if it was a larger study. So for example, if it had a study with both children and adults, they would include it, but only look at the pediatric patient data. And also they only looked at studies published in English. For exclusion criteria, they included studies reporting intubation and post-intubation care outside of the ED. So for example, in the pre-hospital operating room or ICU setting, as they wanted to just keep it in that study in this particular population. And then studies reporting intubation by other methods than RSI, studies of patients that were 18 years or older, and studies not reporting novel human clinical research. So for example, reviews, commentaries, survey studies, and studies of non-human animals. So they extracted the data from each study, including study design, setting, demographics, intubation indications, and sedation practices. The key outcomes that they looked at were the use and timing of RSI and post-intubation meds, timing and predictors of appropriate sedation. The risk of bias was assessed using the Newcastle-Ottawa scale for non-randomized studies, which we'll talk about in a second. And then the meta-analysis was conducted for the proportion receiving any sedation, time to sedation, and proportion receiving appropriate sedation. So what is the Newcastle-Ottawa scale? It was developed to assess the quality of non-randomized studies with its design, content, and ease of use, directed to the task of incorporating the quality assessments in the interpretation of the meta-analysis results. And for the statistical analyses, they used a random effects model using R and RStudio, and then they applied visualizations were created using Tidyverse package, also through R. The standard errors for median time to post-intubation sedation was estimated using the interquartile range divided by 1.35 times the square root of the total number. The pooled estimates for proportions were calculated based on the proportion of patients receiving post-intubation sedation or appropriate post-intubation sedation using the variance of P times 1 minus P over N. And then heterogeneity was assessed using the Egger test, which is a statistical method used in meta-analysis to assess publication biases, and it typically is presented as a funnel plot. And then the grade system, or the grading of recommendation assessment, development, and evaluation, was used to evaluate the confidence in their results. So a total of 10 studies were included in the review. 6 of those were retrospective cohort studies. 2 were before and after implementation studies. 1 was a cross-sectional observational study, and the last one was a preliminary analysis of a retrospective cohort study. Notably, 2 of them included adult and pediatric patients, and the authors only included the pediatric patients intubated in the ED. The publication years included 2009 to 2024, study periods of 2001 to 2022, and total patients analyzed were 1,500 approximately. So going over the studies, 9 of them were rated as good quality and 1 was rated as fair. Most of the studies were conducted in a single pediatric ED. 3 of them were multi-site. And then briefly going over our RSI meds that we commonly saw included Intomidate, which is our induction agent to provide amnesia, blunt sympathetic responses, and improve intubating conditions. And that was followed then by ketamine and midazolam use. As we all know, we typically don't use propofol in pediatrics just because there's a higher risk or rate of propofol infusion syndrome, which can lead to high morbidity and mortality. But interestingly, we'll talk about in the next results that some propofol was used for post-intubation sedation, which may also be due to some of the studies that were including adults. And then for our neuromuscular blocking agents, we used rocuronium most commonly, which is a non-depolarizing paralytic agent, again, to prevent and minimize adverse physiologic responses to airway manipulation, including tachycardia, hypertension, and elevated intracranial pressure, and which was then followed by vecuronium use. And we saw less of succinylcholine use, given that it's also used in most patients, except for those with malignant hypothermia, hyperkalemia, burns, crush risk, and so on and so forth. So going into the results of post-intubation sedation, we most commonly saw fentanyl, morphine, midazolam, and lorazepam, propofol, and ketamine use afterwards. However, all of the studies' outcome measures were varied in terms of timing, proportion, or both. As you can see from this table, not all of them even listed which intubation indications they had or sedation agents, and also the timing of both of those. So we had limited information from the studies that were included. But overall, the time to sedation ranged from 9 to 46 minutes. Sedation rates varied from 24 to 100%, with 100% only in two small subgroups with an N of 8. Only 4 studies defined quote-unquote appropriate timing, but the definitions varied significantly. And then appropriate sedation rates range from 28 to 58%. And then overall pooled estimates with any sedation, there was only 77.3%. But as you can see from the I-square, there was a high heterogeneity. The median time to sedation was 18.6 minutes, again with high heterogeneity. And then for appropriate sedation, it was 43.5%. And then for overall confidence in results, it was pretty low just from their grade assessment due to the observational study designs, the high heterogeneity among all pooled estimates, and then the wide confidence intervals. So for the studies analyzed clinical factors influencing sedation outcomes, and the findings were overall pretty conflicting. In this table, you can see that one of the studies found longer acting neuromuscular blocking agents were linked to lower odds of timely sedation, and then others found that shorter acting neuromuscular blocking agents was actually linked to higher odds of sedation timing failure. So their overall conclusions showed that the evidence was limited and low quality with high variability in sedation timing and methods. Given that around 50% of pediatric patients receive post-intubation sedation, though quality efforts have been increased, no studies actually reported critical outcomes like awareness under paralysis or psychological distress. There are also inconsistent definitions of appropriate sedation timing, variation in drug duration of action, and then long-acting neuromuscular blocking agents were used in 67% of the cases, which may highlight the need for proactive sedation to avoid awareness under paralysis. But overall, future research should focus on standardized studies to improve sedation practices in the pediatric ED. So overall generalizability and some limitations. There were no randomized controlled studies. Most of the evidence was observational. For the quality assessment itself, some of the components within it overlooks challenges like small sample sizes, non-generalizable settings, and outcome definition variability. And then there is heterogeneity in the practice sites, including the time periods, inclusion criteria, and sedation agents limit the generalizability. Given that there are also few multi-site or community ED studies, there's a lack of data on sedation agents, dosages, and safety outcomes in those areas, safety outcomes being coma, delirium, and awareness under paralysis. But overall, the future research should focus more on defining sedation agents, side effects, safety outcomes such as oversedation, unplanned extubation, and hemodynamic instability, evaluate patient-centered outcomes like sedation levels and awareness under paralysis, and then aim for a more standardized approach. One of the other critiques that I would say, just because I think it would be interesting, is that it would be interesting to include an author that is a pharmacist just to provide more background on some of the medications, given that this was like more of an overview of a lot of them, but it doesn't go as in depth as maybe a study with a pharmacist may go. And with that, thank you all for coming, and I'd like to open the floor to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.